What is strange is I did try to...
Good morning. I'm Steph Bertozzi, and I'm the no longer new dean of the School of Public Health at Berkeley, although I'm still learning, so I feel like I'm still reasonably new. And it's my great pleasure to welcome all of you to the event and to the Right Care initiative. I was here very briefly when I was completely brand new a year ago, and I felt like it was the beginning of my re-education on the U.S. healthcare system. And that's still very far from complete. I'm a global health guy, and one of the best parts of my job over the last year has been relearning what's happening in U.S. healthcare. And I have to say, it's an incredibly exciting time. When I got into health economics, I did it in the middle of medical school. I actually ended up switching from neurobiology into health economics because I got involved with organized medicine, and I ended up on the board of the AMA, and I was fascinated by the intersection of medicine, economics, behavior, providers, et cetera. And then I decided, I think early on, that it was going to be a lot easier to do that in developing countries than it was to try to wrestle with the US beast. And now when I come back, it's incredibly exciting because I think we're at a threshold, we're at a break point that people have been anticipating for a long time. I know they've been saying for a long time that we're there, but I actually believe we really are there. When I was studying this stuff in grad school, Jack Wenberg was king. We had just had the revealing of medical practice area variations. There was this sense of, wow, the domination of the myth that science drives everything in medicine has just been broken because we've had unexplicable variation revealed by Wenberg, and that's going to change things dramatically. And I think it really was the beginning of an enormous change in the U.S. healthcare system. And what we now have is that while I've been out of the country, there's been an enormous amount of application of analytics and data and management science to U.S. healthcare. But my sense from afar is that it's been mostly applied to figuring out how to not lose your shirt as things change, how to make money for parts of it, all kinds of shifts structurally. And now we're seeing the beginning of application in a massive way of the use of data for the benefit of the quality and outcomes in healthcare. And that's what led to this group 7 years ago, what has been an extraordinarily productive partnership. It's been private, it's been public, it's been government, it's been academic. And I'm really excited by what I see in the initiative and really excited by what seems to be happening more broadly in healthcare. I just had breakfast this morning, and I just see extraordinary potential. So I want to congratulate those of you who were smart enough to think 7 years ago that this might be a good idea, and the people who've kept it going, my predecessor and colleague, Steve Shortell, next to me. Hattie, I don't know if you've been in it from the beginning, but I know that without you, this whole place would implode. And I want to express my appreciation to all of her support staff who've made this possible, because it looks like the arrangements are working so far. We'll have to see how by the end of the day, how things look. But anyway, I just want to express my enthusiasm and also the sense that if we are at this threshold, for me, one of the big questions is what role the academy can play going forward. And I hope that informally and formally that you guys also push us, because one of the things I worry about is that this acceleration of the use of data in health is starting to move faster than the academy can keep up. And one of the things that on our side we have to think about is how do we adapt our cycle times to what's happening in the real world. And I think that's a really interesting challenge for us, and something that we that is going to change the way the academy works. I'm going to recognize a few partners. The public-private partnership now includes new and additional government partners, and I'm not well informed enough to know exactly who came on when, but they include U.S. Health and Human Services Agency, they include the Veterans Administration, the California Office of the Patient Advocate, the Department of Public Health, the Department of Healthcare Services that oversees the Medi-Cal program, and our most significant association partners, California Chronic Care Association, the American Medical Group Association, and the American Heart Stroke Association with their Million Hearts National Joint Campaign with HHS. I had a meeting the other day with Hattie and Steve, and I said, you know, I'm so excited by what I see in terms of the data that we're going to talk about today with respect to stroke and heart disease and diabetes. And I said, you know, what's the quantum jump from that to a whole bunch of other conditions that other people care about? And how do we, you know, broaden the scope? So those may be the three most important things for health groups of health providers and plans. You know, what are the three most important next things from the perspective of employers or patients, and how might we take this initiative and make it bigger? In addition to, I mentioned my appreciation for the staff and Hattie's team, but I also want to acknowledge people who've put green support and funding behind the initiative and help to keep this thing going, and that includes the California Healthcare Foundation and the California Endowment Health Happens Here campaign, Novo Nordisk, Ralph's Grocery Company, Boehringer Ingelheim, Genentech, AbbVie, and the Health Services Advisory Group. And I'd like to give all of them and Hattie and her staff a big round of applause. A sincere thanks to all the present supporters and all of you who could be significantly bigger supporters and help to think about what the bigger and better version of this is in the future. Don't stop thinking about that, please. And with that, I think Shelley has arrived. I knew you were held up in traffic, and it's great to have you here. And so it's my pleasure to hand this over now to Shelley Riard. Thank you all so much.
Good morning, everybody. Thank you, Dean Bertozzi. I appreciate the introduction. I'm really happy to see this great room of people today. I want to welcome you on behalf of the Department of Managed Healthcare to the 7th Annual Right Care Initiative Clinical Leadership Summit. Again, I want to thank our hosts, UC Berkeley, and all the staff who put this together, of course, starting with Hattie Hanley, the director of the Right Care Initiative, our passionate, tireless, relentless advocate for patient health, as well as the folks who worked with her, Carla Verdi, Warren Barnes, Liz Helms, Amanda Liu, and Laura Spatz. Really appreciate all your work in putting this together. As I came in, I also noticed the new director of the Office of Patient Advocate, Beth Abbott. Beth, you want to wave your hand? There she is over here. And I believe, she's here. As well as Dr. Neil Kohatsu from the California Department of Healthcare Services. Dr. Kohatsu, are you here? There you are, hi. And I understand that Jessica Nunez de Ibarra from Department of Public Health is here as well. Hi. This public-private partnership would not be possible without our sponsors that Dean Bertozzi just mentioned, and we really appreciate their contributions. So we're coming together today to review the level of performance on a handful of critically important proxy measures that indicate whether patient care is being proactively managed in critical areas of performance that can prevent disability and death for large numbers of Californians and are measurable and scientifically clear. I personally have family members who have had heart disease. My father, who died at the young age of 52 from, he had also had diabetes and a number of other medical complications, but it was a heart attack that finally, that did end his life. And my sister, Rebecca, who was born with congenital heart disease and also died young at the age of 56 just this past January. So this issue is near and dear to my heart, and to the extent that you all can work hard to prevent death and disability disability from heart attacks, strokes, and complications of diabetes. I applaud you and willing to work hard with you to hopefully end those terrible diseases. As the state's chief regulator of managed healthcare, I urge you all to recognize that this is the wave of the future, that clinical outcomes can be measured for accountability. And while we're making historic progress as a nation and in a state on getting coverage for people, with many millions more insured as a result of the Affordable Care Act, it's not just about having a healthcare insurance card. It's about making sure that the care patients get improve their health and they have access to timely care. We now have scientific interventions to prevent a significant portion of the approximately 80,000 people who die from heart attacks, strokes, and complications from diabetes. So this collaborative effort is creating a support system to reach the triple aim of better health, better outcomes, and lower costs. To support the positive evolution of proactive care management by managed care plans, the department launched the public-private partnership with the University of California back in 2007. 7 years later, the collaborative effort has grown to include Stanford, University of Southern California, Cedars-Sinai, and a multitude of thought leaders to improve care for the benefit of patients and their families. And I thank you again all for being here today. The clinical leaders and research team are here to help support your adoption of evidence-based interventions to improve patient outcomes. Also with us today are five of the co-chairs, both past and present, of the University of Best Practices, who provide tireless leadership for their better prevention and management of heart attack, strokes, and diabetic complications. I'd like to recognize these important researchers and best practices leaders so you can get to know them. So if you would stand up as I read your name, I'd appreciate it. So, of course, our chairman, Steve Shortell, University Berkeley School of Public Health. Arnie Milstein from Stanford Clinical Excellence Research Center. He's not here, okay. Anthony DeMaria from UC San Diego. Steve Deutsch from Cedars-Sinai. Okay. Robin Clark from UCLA. Hi. Parag Agnihotri from Sharp. And Pamela Leish, I hope I'm pronouncing your name right, from Brown and Toland. Okay, great. And then our research leaders, Professors Hector Rodriguez and Susan Ivey from UC Berkeley School of Public Health. Thank you. Jill Joseph from UC Davis. Okay. Jan Hirsch from UCSD San Diego. Thank you. Steve Chen and Lavana Lewis from the University of Southern California. Great. And Amy Tai from Stanford. Thank you. All right. So again, I want to welcome you and thank you for attending the annual RCI Summit. As usual, Hattie has put together a jam-packed agenda for all of us with engaging speakers who have practical experience and we hope you will learn from them. So I hope you'll also stick around to join us at the end of the day for a Heart Healthy reception to honor the award winners, which I'll be announcing later on today. So again, thank you and enjoy your day.
Good morning. I'm Nadine Simons, Regional Health Administrator with the U.S. Department of Health and Human Services and the Assistant Surgeon General. And I'm really happy to be here today. Such an important topic, preventing the leading causes of death in our country. That's pretty important. I'd like to begin by making sure everyone here knows. What do I do with that? Just push that. Yeah. Okay, thank you. Everyone knows about the commitment of the U.S. Department of Health and Human Services, very strong commitment to the prevention of heart attacks and strokes, and it's mainly through our Million Hearts initiative. For those of you who may not know, A Million Hearts is a national initiative. It was launched in September 2011, designed to prevent 1 million heart attacks and strokes in the United States by the end of 2016. This is an overview of why we are focusing on heart attacks and strokes. While we've seen a gradual decline in mortality from cardiovascular disease over the last 40 years, it remains the nation's leading cause of death for men and women of all races and ethnicities. These heart attacks and strokes are the leading causes of preventable death in people under the age of 65. The trauma to families and communities, devastating. $1 billion each day is costing the U.S. economy in medical costs and lost productivity. And this is a particularly big contributor to health disparities. In 2010, the life expectancy for the black population was nearly 4 years shorter than the white population, with heart disease mortality being the single cause of death that accounts for most of the disparity. Million Hearts Initiative is concentrating on 4 strategies: aspirin when indicated, blood pressure control, cholesterol management, and smoking cessation. I'd like to focus on blood pressure control for my remaining few minutes. Nearly 1 in 3, or about 72 million adults in the U.S. have hypertension, and of those Americans with hypertension, about half are not yet under control, and 35 million adults, or about 48%, have uncontrolled hypertension. Of course, this is the national picture. We know many of you are doing much better with your patient populations. Of the approximately 35 million adults with uncontrolled hypertension, 13 million do not know they have high blood pressure. 17 million are aware they have high blood pressure and are being treated with medication but are still not under control. And an additional 5 million are aware of their high blood pressure but not taking medication for it. Now, this is a particularly troubling slide, data here that you can see. The vast majority of adults with uncontrolled hypertension have health insurance, they have a usual care provider, and most have received health care in the past year. 89% have a usual source of health care, 85% with health insurance, and 74% have seen a health care provider at least twice in the past year. So, we know blood pressure control is challenging for a number of reasons, but we have evidence-based practices that are proving very helpful in meeting this challenge. What are some important action steps for clinicians? Well, using HIT, such as registries, adopting protocols to support clinical interactions, and engaging entire teams in these efforts is proving effective. Also, training patients on the use of validated home blood pressure monitors and incorporating readings into EHRs for tracking purposes is found to be a very effective strategy. And supporting patients in their self-management efforts is another area where clinicians have an opportunity to improve blood pressure control. Aside from clinician efforts, healthcare systems have the ability to make widespread improvements by implementing a systems approach to healthcare delivery that includes supporting team-based care and ensuring that all clinicians are practicing to the full extent of their training and skills. And healthcare systems that use health information technology to implement evidence-based treatment protocols will find it easier to identify and monitor patients with high blood pressure. This kind of system change will also help track the quality of care delivered. And what are we doing at the federal level? Well, the department is devoting major resources to the Million Hearts campaign. 2 of its largest agencies, CDC and CMS, were selected as co-leads to bring their collective strengths to this initiative and to ensure coordination of public health, clinical care, and policy approaches to this complex problem. These efforts are focused on both clinical and community prevention. We have recruited many public and private sector partners, from states to health professional societies, health advocacy groups, faith-based organizations, and commercial payers, to name a few. We are also doing a good deal around payment reform, mostly through CMS, but also in FQHCs and other settings. We have a simplified set of Million Hearts measures, for example, that are used in different settings to assess performance, and that performance is now being tied to payments. Delivery reform is also essential. I guess most of you in this room have been involved in model testing, helping us learn how we can enhance delivery to achieve desired outcomes. The federal government is heavily invested in testing such models in both the community and clinical realm. And just this morning, there was an HHS announcement of another $840 million initiative to improve patient care and lower costs by redesigning medical practices to become part of a more coordinated healthcare system focused on patient outcomes. So, to achieve our common goals, it will require all of us working together, and I really appreciate the opportunity to be with you this morning. Thank you.
Good morning, everybody. It's like old home week, isn't it? Some of us have known each other for decades, but the Right Care family has been coming together and growing strong now for 7 years. And it's always just such a delight when we come together statewide once a year to share best practices. It's the people in this room that are really shaping the future of medicine in California, and with our wonderful first University Best Practices co-chair Jerry Penso now having gone to the national level, leading the American Medical Group Association quality improvement efforts. The work is spreading nationally, and so as we grow, I just want to say congratulations to the many more award winners this year, which means we're not only coming together and talking and thinking, but the spreading of best practices is working. So to all the teachers and mentors in this room, and I have to call out one special mentor right now, and that's Dr. Jim Duddle from Kaiser, who the spirit of quality improvement is his soul. And he is this gentle godfather figure in the project who has brought so many people up in their in following best practices. So he's one of our great San Diego leaders. There's so many wonderful leaders in this room. I can't call them all out, but I want to say that without Steve Shortell, the immediate past dean of the UC Berkeley School of Public Health, this project would not exist. When I was asked by the director of the Department of Managed Healthcare back in 2006 to start looking at data and looking at what we could do to improve quality in the state, I called in a favor. After I had worked on bioterrorism and public health preparedness after 9/11 and wrote a report for the Little Hoover Commission, he called me up and he said, if there's ever anything I can do for you, please call me. So 3 years later, he's like, who? No, he didn't. He was wonderful. When I made the call, he was in Chicago, and his secretary patched me through to his cell phone, and he just immediately stepped up and said, absolutely, I'll be there shoulder to shoulder. We'll figure this out together. And he reached out as well with me to Dean Linda Rosenstock at UCLA, and the two of them helped be the wind under the wings to raise up this project along with the Department of Managed Healthcare. So I just want to turn it over to him. The project is always in good hands with Dean Steve Shortell.
Thank you, Hattie, very much. And again, I add my welcome also. I recognize a lot of people in the room, and particularly welcome for those of you who may be here for the first time. Just raise your hands if this is the first time you've been to the summit. Okay, a fair number. Great. Okay. Let me just say a couple things at the beginning. We're going to now get into the substance of the day, going to show some data. And Hector and I then will also give you a little bit of assessment of some of the implications of this, which will lead into the panel that Jerry's going to lead, will lead into our lunch discussion, and then the afternoon as well. One of the things Nadine said I really want to underscore, and you know this, but it's a matter of putting this into everyday action. It's systems of care. It's systems of care. It's care systems engaged with patients that's going to change these numbers. And we have to figure out more effective ways of doing that in all kinds of practices throughout our state, and indeed nationally, of course, but we're focused here on California. The other thing I would do is set at the outset a challenge for each of you, and that is that by the end of the day today, 5 o'clock, whatever we end, that you commit to doing at least one thing differently than what you're doing now, okay? I'm going to hold you accountable to that somehow, right? But what is it that you heard today, informal discussions, whatever, that you're going to do differently that is likely to help us reach some of the goals we aspire to. It's not doubling down. It's not doing some of the same things or trying harder. We know some of the things that will work. The problem and the challenge is execution, day in and day out, doing those things when so much interrupts, right? Everyday life interrupts, habits interrupt, inertia interrupts, how you've been reinforced and rewarded in your organizations interrupt, right? So as you look at the numbers, I don't want us to lose track of the messages and the stories, right? So every story, you need numbers, you also need stories. And today, throughout the day, we're going to be talking about numbers, data, analyses, but also stories and examples. So with that, let me just go through a few slides. And then Hector's going to join me, and we're going to have a little bit of audience participation. Some of you notice those clickers in front of you. Those are not games, to play with. Some of you probably, I saw some of you actually trying that, but no, we're actually going to use them. Okay, so moving on here, just to remind us, as Nadine did as well, look at these figures. They're not good figures, as you can see. 80,000 here in California deaths due to these diseases here, diabetes, cerebrovascular diseases of the heart. If we go back here, the red, as you see, is under 65. Okay, and then the green, you see, of course, 65 to 74, but in particular, focusing on people under the age of 65, 45 to 64. How do we prevent the incidence and prevalence of new diabetics? Of course, we want to manage the current diabetes well, but what about 45 to 64? What about our children? Okay, what about our children? Preschool, school, adolescence, instilling health habits early on that then doesn't progress to some of these other conditions as well. This is the CDC estimates, 200,000 preventable deaths, 6 in 10, more than half, happen to people under the age of 65, the earlier point. And you can see the earlier alluded to as well, disparities, blacks nearly twice as likely as whites, the need to focus, to target. What I take away from this slide, and some of you have seen this for 7 years now, right? These are some of the interventions, and Nadine just went through some of them. These are largely evidence-based. If I would leave 2 words with you about this slide, it is packaged innovation. Packaged innovation, not a one-off. Some of you may say, oh, it's medication management. Put pharmacists on the care team. That'll do it, right? Bunch of other stuff. Self-management programs for patients. Those are all important, but it's likely that they need to be put together as a package, and the interdependencies involved and reinforced. It's several things. There's no magic bullet here. There's no silver bullet here. It's packaged innovation, and your job as managers and leaders is how to put together those packages and get people working as a team to deliver that with patients at the center. So that's what I take away from this slide. We can blow it up, of course. These are some of our current activities. Hector took the lead, our team, on an article that was published this past year where we interviewed some of you as leaders. We took, and you'll see the data in a minute, we took the highest performing among you, and we went out and interviewed you to find out how is it you're accomplished some of these things. And that article is available. If you haven't seen it, we can send it around. One of the interesting findings, though, as I recall, doing a lot of interesting things packaged, but the use of teams that's been talked about, even among the high performers, there's quite a ways to go in putting together these teams working with patients. So that's something we may want to consider further as we go through this. So there's the article, etc. Okay, and where we are now, if you look at those who have achieved 90th percentile in at least one of the metrics, about 20% in terms of the medical groups have done that, about 40 out of 200, and roughly half of the health plans, and you're listed there as well. But that's sort of a low bar. That just means on one of the metrics. So let's go through the metrics briefly here, and you have a hard copy of these as well. So see if this works. So here we are with the blood pressure among California health plans. This is for all patients now. And the 90th percentile will always be the bar in black. That's the nation 90th percentile. As you can see here, as in the past, Kaiser South, Kaiser North, and the Chinese, when they joined the Chinese Community Health Plan, also here as well. And you can see the others. Now, the encouraging thing I take away from this figure here is, for the most part, these lines are going up ever so slightly, or at least they're holding the gain, but a little bit up here, big up here, okay? So this is headed in the right direction. The actual numbers are here, if you want to drill down, and there's the 90th percentile. But the only ones above are right there. So that's on the blood pressure. Let's look at lipids for diabetes patients. And as you can see here, again, we have Kaiser North, Kaiser South, and Sharp Healthcare 2011, also slightly above the national average here. And here, though, if we look at the other plans, these lines don't go up so much. They actually go down a little bit, as you can see here as well. If we look at the next slide, is heart patients now with the lipids controlled, the LDL under 100. And again, the story is Kaiser, North and South, about the only one above the national average in the 90th percentile. And here of concern is most of these trend lines in the last couple of years tend downward, okay, for heart patients. So some work to be done there. And then finally, here we have the percentage of patients diabetes with blood sugar under 9 here. Some would say under 8, but we're using under 9, et cetera. And as you can see here, we have, again, Kaiser North and South about at the line here. This here, I think, was Blue Cross, was doing well early on, has come down. And for the most part, the other plans, these lines in recent years slope down. So again, blood sugar being an issue. This then, you have hard copy in your packets, just shows the numbers that you see on the figures. But interestingly, if you're curious about what's happening across the country and who else is getting into these 90th percentiles, you see the list there. And you can see, here's Kaiser, of course, HealthSpan Integrated Chinese Community Health Plan, that's great. Gunderson in Wisconsin, Harvard Pilgrim, St. Mary's, Tufts, Health America, Dean Health Plan. And what I know about those, some of you may know more than I do, they put into place these systems of care and make this a day-to-day priority. They are compulsive and neurotic about working with these patients to make sure these things stay in control. It is one of the distinguishing characteristics of some of these other plans that you see in the nation's 90th percentile. So that's on the cholesterol. There's the diabetes, and you'll see some of the same ones. Again, one of the interesting things to me about healthcare is we have very few, if any, organizations that are outstanding across the board. You know, when you think about that, they may be in the nation's top whatever on heart disease or this, that, or the other thing, but they're nowhere to be seen on other things, right? So we have no high performers across the board. And that even includes organizations to some extent like the Mayo Clinic, who begin to get there, or Intermountain Healthcare, or Kaiser Permanente, for that matter. But here you do see a few that are also, again, you see Dean Health Plan here, et cetera, Harvard Pilgrim, Gunderson's there again, et cetera. So if you do well on one metric, why wouldn't you do well on some of these others? And there's for